Hello, my name is Rick Bucata, and I'm the Medical Director here at the Center for Medical Education. Can I have a minute to tell you about the National Emergency Medicine Board Review course? We're now in our 24th year, and we've had over 31,000 participants who've come to depend on our course to help them prepare for and pass their boards. Why consider our course? The NEMBR was designed to achieve one goal: to provide you with the key information you need to pass your emergency medicine cert or recert exam. The course is a 35-hour boot camp that will immerse you in the core database of emergency medicine. Here's why we believe so many physicians have entrusted the NEMBR to be part of their board review program. First, we focus on material likely to be covered in the exam, with no fluff or nice-to-know material to distract from the retention of core materials. Next, the course faculty is composed of enthusiastic emergency medicine educators, 3 of whom have won the ACEP Education Award. Most are residency program directors, and all of them know their stuff. They're engaging, entertaining, and inspiring. And in addition, we have 2 sessions on test-taking strategies specifically designed to help you become a good test taker and in the process ace your exam. Plus, you'll have access to 1,200 high-quality review questions provided in the Aldine and Rosenbaum question bank, and be able to earn up to additional 40 hours of CME credit. And finally, we're so confident in our course that we offer a 100% money-back guarantee. If you don't pass, you don't pay, period. We know you have a busy schedule, so you can participate in the NEMBR at your convenience. If you can't attend a live course and want to prepare on your own, the fully accredited self-study version of the course allows you to prepare in the comfort of your home, car, or at work. However, if you need to get away from distractions and want a focused, immersive, and intensive experience, then take our live course. The bottom line, whether you take our self-study course or our live course, be assured that the NEMBR will give you the knowledge, confidence, and test-taking skills you need to pass your emergency medicine certification or recert exam. And one final point. ABEM allows you to take your recert exam up to 5 years early, and if you do, you'll be certified for 15 years instead of 10. For many of you, it will be the last recert you'll ever need. So avoid the unknowns of having to deal with the hassles and uncertainty of any new recert process. Get it out of the way and take the recert exam and have the peace of mind knowing that you're potentially earning up to 15 years of certification. Thanks for listening, and bye for now.
So I've done a little bit of this stuff and really looked at test taking and where the pitfalls are, and we're going to talk a little bit about it. Test taking tips: obviously read the question carefully, note the key words and the red flags that are in there. Once you've decided a choice is wrong, cross it out, don't go back to it. It's off your pay. It's wrong. You've decided that, it's done. If part of the answer is wrong, it's all wrong. There's no reason you're going to buy on something that you know is wrong. It's okay to guess. In fact, you should be guessing, and in fact, what I'm going to talk a lot about is if you had a question with 4 choices and you didn't know anything about the question at all, you'd have a 25% chance of getting it right. If you can eliminate 2 choices, your chances of getting it right go up to 50%. And so being a good guesser and getting your choices down to, I don't know the answer, but I know a little bit about it, is a real skill, and we're going to talk about that. That requires what I call FOIL analysis. We'll get into that in a moment. These are some other things that come up. Unwordy, familiar stuff is wrong. All, none, always, often wrong. Don't choose the thing you read last week in the Annals of Emergency Medicine, if you were reading the Annals of Emergency Medicine at all. But, you know, it's the gold standard stuff. It's not something that's ancient. It's not something that's brand new. It's going to be well-established sort of concepts. Outdated stuff is wrong. Negative behavior is wrong. They generally want you to be active, right? Emergency medicine, you're supposed to do stuff. This idea they come in with we'll let it mature and come back in 3. No, drain it now. Be active. I'll skip this. Calculations, people get hung up on these. If you think you know a formula, you've done the calculation, and the answer isn't there, 1, check your math. Do it again, slowly. If it's still not there, they're using another calculation. So start racking your brain to think of another calculation. And people get hung up on these and waste a lot of time sometimes sort of disrupting their test taking. These are sort of standard calculations that are out there. But none of these tests are time dependent. Whether you're doing the primary cert or the recert, there is more than enough time on these. They are a little bit of an endurance test, right? The primary cert exam's a couple hundred questions, and the research a little less than that. But there's no real, you're not going to be crunched for time on these. But if you're going to do real FOIL analysis, it takes time and it's work, and that's what we're going to get to in a moment. There's always this stuff people always ask, if you have no idea, why would you choose B or D? There actually is a reason why that's true. It has a lot to do with the English language and verbs and vowels, and I could go through it with you. It turns out that it is B or D, but I'm not going to get into that right now. But if you are going to guess B or D if you know nothing. They always say don't study the last day, and I remind myself that I'm talking to emergency physicians. Don't study the last day unless it's the only day that you're studying, in which case, have at it. These testing centers that you're going to go to write them, right? Make sure you know where it is. If you haven't been to it before, don't put yourself in a situation where you're in traffic trying to get there in the morning and things. Go there the night before if it's a couple hours drive or something like that. And they're going to have a locker for you. They're going to take everything away from you. You're going to go in there with a pencil and scrap paper, and that's it. They're going to take your watch. If it looks like it does calculations or it's a smart watch, they're going to take everything away so you can't cheat. Can't have information on it. Get comfortable. Be well rested. Titrate your drugs. Not too much coffee, but not no coffee. Know what your amount is. You already all know this. Harness your test-taking persona. I'm an angry test taker. I'm hostile towards the exam writers. But I don't want to be too pissed off because then I don't focus. Some of you in the room are like those granola-eating, calm, test. If that's who you are, that's fine. And you should know what your test-taking persona is. When you're doing practice questions before you go take these tests, because you've been out, you've been working for 20 years now or 30 years, you were once a lean, mean, multiple-choice machine. You aren't anymore. And so you have to get back in that swing. And a lot of you right now are doing like 10, 15 questions, 20 questions a night kind of thing, doing a little practice. That's fine, but if you're going to run a marathon, you can't be doing 1 kilometer runs every day. You have to, as you get towards the race, you got to start doing 100 questions at a time, 150 questions at a time, because it is a little bit of an endurance test. And so you need to get in that mode as you approach test day. On the computer, has everyone done the computer thing yet? Anyone not? So there may be a few of them. So you're going to be on a computer. That I don't like that because I used to like to write on my exam paper. You can't do that anymore. So that's a little bit of a problem, but you do have scrap paper. But the questions are in blocks of 20 or 30, and once you leave that block on the computer, you cannot go back to it. So in a sense, it's sort of like 5 little exams of 30 questions or something like that. You got to do the block completely. You won't be able to go back to it. When you're done with that block, you're done. So be aware of that. All right, now for what we're really here to talk about, which is a question and what are the parts and what are the types of questions that are out there. And you really don't know this stuff if you're an exam taker. When you really learn about this is when you write exams for people to take. And having written just exams after exams during my 15 years in the residency office, you learn, and having been an item writer at various times, you learn that there's a little anatomy to these things, and once you are in that mindset, you'll realize how hard it is to write a good question, a direct good question that has a specific answer, and then to come up with 4 bogus choices is not easy. Now, I think they've changed the exam to 3 bogus choices now for the research. It's going to be 1 correct and 3 bogus. The difference between having to make 3 bogus and 4 bogus choices, it is so much harder to write 4 bogus choices. Now, when you think of the exams you've written, in-service exams and board exams, I want to point out a couple things that you probably notice. Like if I was to ask you on a typical exam, 200 questions, emergency medicine, how many times do the words Guillain-Barré show up on the exam? Like 5 or 6 times. It's only the answer once. Why would it keep showing up? Because they know they can put this hyphenated French-sounding thing on an infectious disease as a wrong choice. They can use it on an infectious disease question, a neuro question, a diarrhea question. So they use it over and over again. Eaton-Lambert, there's another one. Why is it all over the exams? I've seen like 1 case in my whole life, but it's on every exam. And what this shows you is that the exam writers are trying to come up with bogus choices that you won't feel that familiar with. And I can write the exact same exam, 60 questions, same question, same answer. And just by changing the wrong choices, I can dramatically change how hard that exam is. You would think that changing the wrong answers wouldn't have anything to do with the exam. Same right answer, same question. Shouldn't it be the same? Oh, no. And you can make an exam much harder just by putting a few destabilizers in there. So let's go over the anatomy of a question. There is the question, and it may have some preamble, and then there's the question. Then there are the choices, 4 of them, of which one is right. So there's the answer. And then there's the 3 foils. And what I'm going to talk to you about when I've worked with people who are struggling with exams is how much work they do or not do on foil analysis. I can change the average score of a person, and I've done it multiple times with people over the years, where I don't change their knowledge base, I just change how they're looking at the choices. And without changing your knowledge base, I can improve your score about 10, 15 points just by getting better foil analysis out of you. So let's get into foil analysis and sort of the mindset that you have to have when you're taking a question. And you want to know what kind of question there are, and there are several different types. We'll go through them. But here's a classic, exam question. It's a fact question. It's not like you know the entire animal kingdom and what gets rabies or not. And they ask, which of the following does not transmit rabies? So it's got a negative in it. Most exams don't want you to do that anymore, where they have, because it requires you to sort of double negative it in the logic. But anyway, work with it. So here you are taking the test. All right, does not transmit rabies to man. Pretty reasonable, because if it does, I need to give them the rabies vaccine. All right, A, raccoon. Yeah, I think raccoons can. I can't remember the last case I heard of raccoons, but that's what you're thinking. B, skunk. I think skunks can. Yeah, they're, these are mammals in the United States. C, mongoose. You're thinking to yourself, you're thinking about the exam writer, you're thinking, assholes. By the way, these exam writers, they're smarmy about this shit, because there are mongoose in the United States, in Hawaii and the U.S. Virgin Islands, and they do carry rabies. They know you don't know that, so why would they put that in there? Why would they pick because it's a destabilizing choice. This is about whether you sweat during the exam or not. So you're like, shit, I don't know anything about mongoose. Ricky Tikki Tavi, the Jungle Book, I don't know. So you're kind of stuck. And people who are not good at taking exams give up. They literally just throw their arms up and go, I don't know, maybe it's mongoose because I don't know anything. You got to stay cool. Can't lose your cool. So you're like, mongoose, assholes. So then you go D, rabbit. You're like, I don't think rabbits do. You might even remember something about lagomorphs, which rabbits are. Bats, you know the bats do. There's been all the talk about bats. So if you're a normal person taking the exam, you know that it isn't E, you know that it isn't B, and it isn't A. And that leaves you with C and D after you're done with your foil analysis. And you should be thinking to yourself, would the American Board of Emergency Medicine really fucking want me to know mongoose? It's got to be rabbit. If you choose mongoose on this, you're an idiot. And yet, when I talk to people who take exams, they get in this flustered state and they choose things like they fall for the damn mongoose. You should know it's not the mongoose, because you're trying to think not only about what you know, but what you're trying to get yourself in the examiner's mindset. Would they really ask a question where I'm supposed to know mongoose? No, they wouldn't. That would be crazy. The thing about fact questions like this is you can't really figure them out. It's not like it's a concept that you can figure it out, but you can sort of think about it and ask what the examiner might be thinking, but you should definitely get that one right every time. Then there are these make the diagnosis questions. These kind of irritate me because they give you this thing. They say, what is the diagnosis? This is a typical one. This is classic. I'm going to show you something else. Here's the item writer writes this question. 28-year-old woman on birth control pills, oral contraceptives, presents with gradual onset chest pain, myalgia, shortness of breath. Okay, that's, all right, that's not that specific. She got shortness of breath. She got the birth control pills. They know that they've already fired the PE thought in your head. They know they already triggered it with the birth control pills and the young woman who's short of breath. Don't go too fast. They also know you're an ER doc. You know what they say about ER docs, right? We never met a conclusion we wouldn't jump. Don't jump to conclusions. You got to stay cool. The pain is much worse when she lies flat. That's an odd thing for them to go out of the way to tell you. And so you should be thinking, does PE really have a lot of positional component to the pain? Not really. Which diagnosis is most likely? So you're like, I don't know what the hell she has. That would be a normal person's thinking when they hear this. So you're like, all right, let me just see what they offer up. Maybe by looking at the things down there, I'll get some idea. Dressler syndrome, you're already a little pissed. If you're me, the blood pressure's already coming up. Dressler syndrome. Can't remember much about it. That's the post-MI autoimmune thing. All I remember is like 4 to 6 weeks later. Doesn't sound like that. Chagas disease. Oh. I'm really, inside my mind, the string of profanities is impressive at this point. The vein is coming up. Now I'm trying to really stay calm. I don't even know where the fucking apostrophe goes. Did they misspell it? I'm like really pissed. But because I've written exam questions, I'm like, that's just like mongoose, you assholes. I'm not biting on Chagas disease. It's not like I'm writing the tropical medicine and hygiene exam for the fucking London school. So I'm going to hold Chagas. I'm going to stay cool. Acute pericarditis. And, oh, she's young. Oh, yeah, the pericarditis is worse when they lay flat. Remember, they always want to sit forward, lean their heart out. You're like, oh, that sounds good. And then you start thinking about it, and you go, but the jerks put the oral contraceptives in there. And you realize that's a red herring. And before you jump on the idea of the red herring, you should then be thinking, they shouldn't be trying to trick me. What's these jerks? Why would they? And you should ask yourself, is that a legitimate red herring to put in a young woman of reproductive age in the questions? Oh, shit, yeah, that's a totally reasonable red herring. So now you're like, okay, that's okay of them to do that. That wasn't that mean. Okay, acute pericarditis is sounding right. We've already talked about pulmonary embolus isn't sounding right, and TT syndrome, which is costochondritis. So again, you have to really do the work down in the question where you're looking at the different choices, one of which is right, the others are foil. You got to weigh them against each other in the context of the question. There's a lot of people who take a test who just read the question and they're looking for something familiar, quick, that's an answer, and they never do the work that's required, that takes time to compare the different choices to each other and how they specifically pertain to the question. And that foil analysis is the difference between a good test taker and a bad test taker. And I could take someone who's like on the cusp of failing, teach them how to do foil analysis and how to study doing foil analysis. And like I say, on average, I can improve scores like 15 points without a knowledge-based change. Two-parters, I used to hate these. A hiker from Connecticut presents with a Bell palsy and a rash. Like, all right, it's a Lyme disease, which means it's wrong. The question's already wrong, because if it's Lyme, it's not Bell. Can't call it that. Bell's idiopathic. He just went through that. But anyway, I'll humor them. What treatment is best? I'm like, I don't know what treatment is best. I got that little book with the Chinese things on it, or I look it up. I don't remember every bug and every drug, you jerks. So now I got to figure it out. And again, some people panic. They give up. They're like, I don't know which one it is. Or you might know, it's doxycycline. Shit, doxy isn't a choice. So now you're looking at it. You got to figure it out. All right. Amoxicillin 500 TID 10 days. Might be. Sounds reasonable. Head CT and NSAIDs. That's not a treatment for anything. It's wrong. B is off the list. Bactrim. That's a broad spectrum antibiotic. Could be. Valcyclovir for 7 days. This isn't viral. It's the spirochete. Valcyclovir again. So, all right, so good. I got D and E is wrong, and I got B is wrong. And again, a lot of people, and I've worked with lots of people on these things, they just give up. They're like, all right, I'm going to guess A or C. I'm going to go with the Bactrim because it's more broad spectrum. No, that's not all the information is there. You're not done yet. It's amoxicillin 500 TID for 10 days versus Bactrim BID for 3 days. If you know anything about Lyme at all, a disease that causes carditis and cardiac blocks and arthritis and CNS invasion with bilateral seventh nerve, what are the chances that you treat that like cystitis for 3 days? That's not going to be a 3-day treatment. In fact, the treatment for it is amoxicillin 10 to 20 days. Some people recommend really long courses of antibiotics for this. And so if you did the rest of the foil analysis and looked at the other information, it really should be straightforward. This is not going to be a 3-day treatment. So even if you didn't know the antibiotic, there's only 2 antibiotics there, only one of them has a duration that's reasonable. So even if you knew nada at all, or all you knew was doxycycline is the treatment, you should get this question right because it's not going to be a 3-day therapy. So look at all the information given before you jump. Then there's these long questions. When I was a resident, before I wrote questions for other people to take, when I was a resident and I saw one of these questions, they also sort of irritated me. Here's the question. My thoughts are, what? Reading comprehension 101? Like, ask a goddamn question. Why do I got to read 3 paragraphs? We'll get to what's happening here. But once you write questions, you realize that they're hiding the facts. This is all about you finding. How many features do you need to know to make a diagnosis? Do we talk about diagnostic dyads? No, we don't. We talk about diagnostic triads. So here's a hint. You see this much words, you're looking for 3 critical pieces of information to tell you what's going on. 3 things that go together. All right, so let's start. 75-year-old man, old, weak, dizzy, and nausea. That's all useless. It's all very non-specific. He's old, he doesn't look good. He's a DLG so far. With ataxia. Don't fall for ataxia. Ataxia is a hard neural finding. That's important. So he's old and ataxic. I got 2 important features. All right. Over the last 2 weeks, he's confused and unable to provide a past medical history or family information. That's a bunch of bullshit. That was not helpful whatsoever. In real life, I love it, right? Review of systems not available. All right. So that doesn't help me at all. He denies seizures. Well, I don't know why I'd really care what he denies because he's confused. But anyway, he denies seizures and they go to here's again one of these peculiar sentences. They're trying to say something. He denies seizures and has no evidence of ton biking. I got it. He didn't seize. But his pants are soaked with urine. All right, he's an old person from the nursing home. They all come in diapers. I don't know. His EKG is normal. Oh, thanks. That seals it. Then you get to the question, which diagnostic approach will have the highest yield? This is very typical item writing. I have no idea what this person has at this junction. But I'm going to have to do FOIL analysis and relate each of these things. All right, so I'm like, I got no idea. You might be thinking the chances of me getting this question right are low. I've got no clue what's going on. I got all this sort of non-specific weird stuff. The only thing I got really is ataxia. All right, so let's look at it. A SED rate to rule out temporal arteritis. Well, temporal arteritis, I know about that. It's old people. It's women more than men. High SED rates, right? They got an ESR like 70 or higher. It's a disease of the 7th decade. It's the right age for he's the right age for it. But they usually would say something about blindness or scalp pain or bumps on the head that hurt. There's nothing in there that sounds like that. A is out. I know not a ton about temporal arteritis, but I know that ain't it. Then they go, a head CT to assess for normal pressure hydrocephalus. To which you go, what do I know about normal pressure hydrocephalus? And you might be, and I might have been when I was a resident. You know what it's like when you're asking these questions in the exam. It's very disturbing. What do I know about that? File not found. But maybe as you do some deep hippocampal retrieval, you'll remember something about wet, wacky, and wobbly. Oh, yeah, does that work? Hang on, let's look. All right, hang on. Maybe it is that. You're thinking to yourself, I get it now. The wet pants with no seizure is incontinence. I just learned something. All right, he's ataxic and incontinent and confused. All right, a head CT, maybe that is normal pressure hydrocephalus. You'll be thinking to yourself, maybe I just learned something. Better look at the others, though, before I latch onto it. C, LFTs to rule out hepatic encephalopathy. There's nothing about this here that suggests hepatic encephalopathy. No mention of drinking, no mention of a flap, no mention of jaundice, no mention of anything that goes with that. GI bleeding, nothing. C is out. CPK-BB. What is this, 1925? No one orders a CPK-BB for anything. That's wrong. So C and D are out. Carotid angiogram for Barry. There's nothing that sounds like a Barry aneurysm. This sudden headache, worst of my life, ruptured aneurysm. So you actually learned that this is normal pressure hydrocephalus. Old, ataxic, incontinent, and confused. And if they'd asked it this way, geriatric patient with ataxia, dementia, incontinence, where they spelled out the triad, that would be too easy. So what they did instead was they hid the triad, and you should be thinking whenever you see a paragraph like this, you're looking for the hidden triad. There's going to be noise, there's going to be music, and your job is to figure out which of those three things are notes to the same song. And here you got all three notes for the song of normal pressure hydrocephalus. You might think, come on, it's my fourth recert. Can't they just ask a few concept questions that are reasonable for me to stay on the floor and maintain my license? Concept questions are super hard to write. Here's one. Which of the following organs is susceptible to barotrauma? Oh, the concept of barotrauma. I like that. That's, pressurized gases and things. We talk about it with the lungs and diving injuries and Henry's Law, Boyle's Law, all that stuff. I know about that. All right, let's do it. I should be able to figure this out. It's a concept question. I should figure it out. All right, which of the following organs is susceptible to barotrauma? Liver. There's no air in the liver. There's no gas in the liver. The liver, I never heard of anyone having a liver dive injury. No. Spleen, it's just like the liver. It's just on the other side. No. Sinuses. Oh yeah, people get sinus stuff when they're diving. They get sinus squeeze and sinus expansion. You're like, oh, maybe they got gases in it. It might be good. D, spinal cord. Now, I know they get the bends involving their spinal cord, but that's not barotrauma. That's dissolution of gases. So this is not a bends question. D is out. Heart. There's no air in the heart. So you're like, all right, C. But if you're me, remember when you used to do the in-service exam, you could mark it with an X in the old days with the written exam, which meant you thought the examiner should see what you have to say? Oh, I know they used to get together. I could just see the people who wrote I got Mallon's test. Let's go get a few beers. This should be good. What would I write on this test? I would put a big X. I would circle sinuses. I go, I think you mean the sinuses, which are gas-filled, you assholes. And I would say, I would write that in there. However, I would expect the board examiners in my chosen field of choice to realize what a fucking organ is. The sinuses are not an organ, last I checked, you dumb cough. And that's what I would write on the exam. So the question is inappropriate. It has no correct answer as written. I did my best to get the incorrect answer that I thought you wanted, which was sinuses. That's what I would write on my exam. There'd be like 20 of those on my exam. I'm sure when they got those back, they'd be like, yeah, this should be fun. But again, we're talking about this concept of foil analysis. There are research questions on the test. I remember one year I wrote the test, and there were like 4 questions on when a retrograde urethrogram is indicated. Oh, very similar, slight different choices, slight different things. And I was almost certain at the time I was taking the test, these are research questions. Just do your best on them. They probably were research questions. And why do they bother to ask it 3 different ways? Because they're trying to see how the question performs. They're going to correlate whether you got this version of the question right or this version of the question right and how well you did on the exam. All of the questions that the American board is using on these exams have all been Pearson correlation coefficient tested. They know exactly whether it's a hard question or not. They know if they change the choices, they can make it a little bit harder. They know everything about how these go, and that's why they don't want us talking about these exams. These questions represent hours and hours of work, vetting, testing them, changing the choices. It's really hard to write a good exam that would valid. Remember when they told us they were going to put the LLSA stuff into the exam? Oh, we're going to ask a little more detail about, and then how long did it take before they said, oh, we can't do that? Because it destabilized the exam. They couldn't bring in that much information. If you want an exam that's a high-stakes exam for your board certification to have very stable performance properties, that means you can't bring a lot of new information and new questions on at any given time because you will upset the apple cart and the performance of that exam. And that's why when we talk about in these lectures about there's new material that could be getting in there, we don't say that very often. The exam marches forward relatively slowly, and they need to have time to check all those things. So, foils. If you were studying, let's say you were about to do 100 questions, and you were about to do 100 questions. Every time you pick a wrong choice while you're doing your practice questions, and I don't have any stock in any, whether it's 1,200 questions, Roche review. If you're going to do the peer exams, they will freak you out because they're hard. I like peer 5 the best if you can find it. A lot of residencies near you might have copies of peer 5. But while you're doing it, if you get something wrong, write it down. Then you're going to go quickly look that up on the computer. I'm not talking about read a chapter in Rosen's. All you want is a 3x5 card with 3 facts about the thing that you got wrong about, ischemic optic nerve. And you're going to know that. And what's going to happen is your list of things you're studying are going to be different from yours because you have different knowledge bases, but you're going to have a customized FOIL list of things you got wrong, but you chose. And because they use FOILs over and over again on exams, that's why the words Guillain-Barré occur 5 times, why the words Eaton-Lambert are all over the damn place, why certain things keep showing up, is because they use those FOILs over and over again. And so if you learned just a few bullet points about each of the FOILs that you'd gotten wrong while you were doing practice questions, that would dramatically improve your exam performance in the future because those FOILs are going to keep showing up. They keep showing up. There's a limited list of wrong things. And so I've always advocated that as, when the exam's a month away, study the stuff you hate. Rheum, heme, whatever it is that you hate. Don't study the stuff you like. As you get closer to the exam, do quick reviews of stuff that's easy to learn that's unfamiliar. Tox, maybe environmental. Those are great to do. You can bang those out. There's always a few questions there. And then the last little bit is short-term memory and your FOILs. Going over the FOILs that you've gotten from your exam participation and practice questions. That approach, whereas you get closer and closer to the exam, you're more focused on FOIL analysis and getting into this mode. Practicing doing questions with detailed FOIL analysis. It's work, right? Now, if you do full FOIL analysis on 20, 25 questions, that'll take you more than a half an hour. It'll take more than a half an hour. The good news is on the exam, you will have plenty of time to do this. There's nothing close on time limiting these that will do it to you. And then every once in a while, I find it to be just good for your heart and soul. When you read a question that you think is ridiculous and you've looked it over and you don't know what it is, you should just say to yourself, fuck it, B. Just to feel good and move on. I don't care. You're stupid for asking it. And we'll end with that. Good luck with these.